So, welcome back, ladies and gentlemen. We have a last session before the lunch break, and I have to apologize to Piotr because for some family reasons, some serious family reasons, he could not come, and he pre-recorded his session, so he's obviously not chairing the session, so I will do with Frank. And this session is about new approaches to VT ablation, and it's my pleasure to invite again Elad to talk about pulse field ablation, animal and clinical data. As we already mentioned here a few times, this seems to be really breakthrough technology also for VT ablation, so we will see in next few years. Elad, please.
Thank you, Joseph. I'll focus mostly on the preclinical because we are awaiting clinical data. So let's start with, there is a new tool, but does it really the right tool for VT ablation? The fact that we have it doesn't mean that this is going to replace what we have until now. So what are the potential advantages of PFA? For AFib, it's very clear, but what are the potential advantages for VT? So there are safety advantages, obviously, for PFA over RFA or cryo. No esophageal damage, not so much important for VT ablation, at least not endocardially. There is no or just transient phrenic nerve injury. That can be an advantage. Safer around the coronary arteries. Initially, when it came out, everything was like perfect, like a first date. Everything looks amazing. And a second date, third date, and reality comes. It's still good, but it's not as good. And this is the data from Vivek Reddy, showing that if you do in all patients, a series of patients, you do right coronary angiography on all the patients, you do CTI, in all of them, you find some stenosis, some narrowing, vasospasm. They call it vasospasm because you still don't want to be very negative. So it's vasospasm, and then you pre-treat it with nitroglycerin, and it gets better. And I can tell you, we had the same information 3 years ago with the preclinical studies. We gave nitroglycerin. We waited for over 2 hours to see an effect. And you know that when you give nitroglycerin for true vasospasm, it resolves within minutes, not within hours. So we knew already that it's probably not only just plain vasospasm. And then at Gerstenfeld, as he usually does, study things very carefully. And when he studied this very carefully, he found that, there is vasospasm, but that's not only it. There is actually mild stenosis due to neointimal hyperplasia. And this is, in my mind, worrisome. And we have similar results in our animals, not ablating right on the coronary arteries like Ed did, ablating by 5 millimeters away from the coronary arteries. We see hyperplasia and narrowing few days later. So this is an issue. So from a safety standpoint, is there an advantage over RFA for VT ablation? Needs to be seen. Now, the other nice thing about PFA, everything is very fast. You apply the energy in microseconds. But then you accumulate all these times of all these pulses and repetition and like this. Does this translate to faster lesions? Let's see in a second. And lastly, the other advantage is that it could be more effective for ablation around scar. And I think that's truly the most important thing about the potential utility of PFA in VT. Now, this is from a study we published a year or 2 years ago. We show that as opposed to RFA, when you repeat the lesion, you repeat an application exactly in the same location, you don't expect so much lesion growth in depth. With PFA, you do have lesion growth in depth. You can quantify it. and you can see that you nearly double the size of the lesion by repeating the applications, but you have to wait between applications. We don't understand exactly why. The assumption is that there is kind of like a preconditioning effect happening. So what happened with the first pulse of an electrical field, you destroy membranes. And then the next electrical field that comes, the next pulse that comes meets more fragile and partially ruptured membranes at the deeper margin of the lesion. And each application can go a tiny bit deeper because it meets more and more damaged membranes. This is just an assumption. Not only the depth is increasing, also the lesion volume is increasing. So there is a repetition dependency to PFA, which is an advantage. But let's see how much does it take in time. So in this experiment, 4 repetitions, we did not find so much added value to do 6 or 8 repetitions. Each application is about 5 seconds, and we wait 10 seconds. Why 10 seconds? We didn't really study this empirically. Maybe Pierre and other people have done it. We did test 5 seconds, which was too short, didn't give us good effect, and we did test 15 seconds, which was not much better than 10 seconds. So that's where the 10 seconds come from. So if you do 4 applications, you are looking at 50 seconds of per site. 50 seconds per site, it's not that different from what we do with RFA. RFA, we do 40 seconds, maybe a minute. We don't do very different numbers. Now, this is with the Sphere 9. What about the Farapulse technology? This is from at Gerstenfeld. Also 4 applications, 2.5 seconds per application. Test 10 seconds between applications, 40 seconds. And with a linear catheter, this is just coming into clinical practice or studies now. We don't assume much shorter lesions. Probably you're going to have smaller lesions because the footprint is smaller, but likely the time of the duration of the application is going to be still in the range of 40 seconds to a minute. So there's not so much improved efficacy as far as time. Now, what about the potential effect in scar? Here I think there is an advantage. So this is a study we have done in swine where we occluded the LAD and waited 2 to 3 months. We used the Sphere 9 to do PFA, not RFA, just PFA from. The system works by applying bipolar and biphasic waves. And because 4 repetitions seems to give you the deepest effect, we did 4 applications. And we ablated in the scar border zone based on voltage and based on electrogram. As you can see, the lava potentials here. And this is how it looked with the intracardiac echo. And the comparison group was not, in this case, the RFA from the same catheter, but was the RFA from the standard ablation we're using nowadays, which is the 3.5 millimeter irrigated catheter. In this case, it was the Cardo system with the STSF catheter. We used 30 watts with a contact force of 10 to 20 grams, and we aimed for an ablation index of 700 to 800. Now, some of you probably already writing the questions. Why did you use 30 watts? Why didn't you use 40 watts or 50 watts? And I'll show you the study that's going to be online next week at JKP. We spent 2 years trying to understand does ablation index make sense in the ventricle? And the answer is that not so much. And when you look on different ablation index values, target ablation index values, in healthy ventricles or healthy myocardium, you see that you pretty much plateau around 700, AI of 700, 800. You don't get much more than that. But other important information from this study is as following, that the formula doesn't really work. Doesn't really work for ventricles. And the reason being is that, look at this, at a similar AI value, ablation at 30 watts makes deeper lesions compared to 40 watts. So if you just target, let's do ablation index of 700. and I'm going to use 30 watts over 40 watts, so what happens is you're going to ablate for longer duration to reach the same ablation index value. And this longer duration is going to give you, for the same pre-specified AI, a bigger lesion. And that goes to, I think what Frank says a lot of times. Duration matters. Duration matters. Just high power, short duration works for the atria, doesn't work for the ventricle. The ventricle needs to be cooked slowly. Now, what happened similarly with contact force? When you use 25 grams as opposed to 15 grams, with 25 grams you're going to get smaller lesions for the same pre-specified AI. Again, for the same reason that in the formula, the value of time proportionally is less. So it's powered less. So there needs to be an adjustment for the formula if it can actually be predictable. I don't know, but if it could be, time needs to play a larger role. So that's the reason we use the 30 watts and 15 grams. Okay, and these are the results. With PFA in scarred ventricle, you can see the scar extending to the sides of the lesion where this lesion is cut in the middle. You can get fairly large lesions because it's a large footprint catheter, but you can also get transmural lesions, which is very encouraging. Now, with 3.5 millimeter catheter, two things are important. Is one, you can get deep lesions, but you're going to get very punctate lesions that are going to fall just where the catheter wants to go. It's not like in the atria that you go over like a smooth surface. So they always tend to center in the areas where all the pectinate goes together to the wall. Now, as far as lesion depth, PFA is equivalent to RFA. When you look on total depth relative to the wall thickness, it's similar. The width obviously is larger with the PFA because it's a larger catheter, and transmurality was better with the Sphere 9 PFA compared to best that we can do with 3.5 millimeter catheter. So it does look good. It does look that this specific catheter working using PFA can give you bigger lesions than the standard today. Now, the biggest advantage, and that was shown in several studies, not only our study, actually the first study was from Ed Gerstenfeld, is that the major difference between PFA and RFA in SCAR is that if you look from the endocardium to the epicardium, and this is the endocardium here, oh, you can't see this thing, sorry. You look on the endocardium, the catheter was here, so you ablate the subendocardial surviving myocardium, as you do with RFA, but then you can't really penetrate with RFA anything deeper to the insulating layer of collagen, where actually with PFA, what you can see marked here by the green dotted line, it's a deadly effect by PFA. So PFA is able to, have an effect on viable myocardium that is deeper to the layer of scar. And it does have even effect even deeper than this, but this is not conclusively irreversible. Now, as we see with all the previous studies about PFA, it preserves the nerves. Is it good to preserve the nerves? Actually, I don't know. But it preserves the nerves in the myocardium, and it preserves the small vasovasorum and small blood vessels. Now, with RFA, this is the comparison with RFA, you have a very nice deadly effect on the subendocardium, but no effect on anything deeper to the insulating layer of subendocardial scar. Now, we wanted to test to see why actually RFA doesn't really work around scar. Because when you think about it, the impedance around scar is lower. You would expect that, and that's why I really wish I had some more background in engineering and sciences, because you would expect if the impedance is lower, resistance is lower, you should actually have an effect through scar, but you don't. So what we did here in an ex vivo bath preparation, we hang normal tissue, normal ventricular tissue, or infarcted tissue. And we put here a 3.5 millimeter thermocool catheter, and we applied the same amount of contact force, 10 grams, and we ablated at 35 watts, 90 seconds in both instances. And what we did from the other side of the tissue, the epicardial surface, if you will, we embedded a thermocouple. But the thermocouple was just mid-myocardial, in the same distance from the ablation catheter. And we measured throughout these 90 seconds temperature in the tissue. And when you do that, you can see that in blue, this is the temperature that developed in the tissue slab that was normal. So temperature rose very nicely, reached 66 degrees. And you can see that actually, even with 35 watts, temperature still rose after 60 seconds. Okay? Suggesting that lesion duration is important. But what happened in the infarcted myocardium? See that you have such a blunt response. The temperature doesn't rise. Doesn't rise distal to the, deeper to the layer of collagen. And it continues to grow, actually, even at 90 seconds. So this is just a glimpse. This is by no means like this is just to test this hypothesis, but it by no means like a study that you can use to understand ablation in scar. But what it does tell us that RFA in scar has a blunted temperature response, and actually lesion duration is very important. Okay. And since then, there are many other studies that showed pretty much the same thing. In contrast to RFA, with PFA, we can target viable myocardium that is separated from the catheter by collagen or fat. And this is the biggest and potentially the only big advantage over RFA at this point. Now, if we just use the Sphere 9 catheter and we want to compare RFA to PFA, because this catheter can do both, with one application of PFA, you get a lesion in the range of 5 millimeter depth. This is in healthy myocardium. If you apply four PFA applications, you get to 7 or 8 millimeter. If you do, from the same catheter, one application so this is 50-second lesion. You remember PFA, 4 applications, 50 seconds. Lattice, RFA, 5 or 7 second, one application, you get 10 millimeter. And STSF, you get obviously significantly less. So RFA from a large footprint catheter gives you, right now, the biggest lesion. So go back to this slide of safety advantages and efficacy advantages. So the biggest advantage in my mind so far is, again, the potentially more effect in scar tissue. Now, there is also potential disadvantages. There is less predictable effect. When you when you have an immediate response with RFA, you have a PVC, and within 2 seconds you terminate, you continue the lesion for 60 seconds, you know that probably you're going to be successful long term. With RFA, you have no clue. You hope that you gave enough energy, but you don't really know what's the component that is reversible from the component that is not reversible. I think more work needs to be done on this. It is titratable by the number of applications, but it's not as titratable, definitely not linearly like RFA. So that's the second thing. The third thing is that you lose EGMs during ablation. So you don't really know what happens since you started ablation until you ended ablation. It may be a short duration, but you don't really know what happens. And lastly, the other potential disadvantage or advantage, as you want to see this, is the greater effect of PFA on the conduction system. On the Purkinje network, maybe in this sense it's an advantage. But what about the AV node, the sinus node? We got sinus arrest that never recovered, one application with PFA on the right atrium. So that needs to be taken into consideration, especially in the non-ischemic patient when you ablate higher in the septum. You want to avoid heart block. So I think this slide have been shown so many times since PFA came out, but I think it's true. Like, this is the Gartner hype cycle for any emerging technologies, and I think this is where we were like at HRS 2018. Looks like everything else doesn't matter anymore, and PFA is going to take over the world. I think now we kind of like here and probably we're going to plateau somewhere there. But I think we need to learn more. So I'll end by trying to answer the question, will pulse field ablation change the results of catheter ablation for VT? Because that's the real question. And the answer, I think, is likely not. It's more effective ablation technologies may be helpful. However, these are more influenced by catheter design. And I think the large footprint of the sphere contribute to its increased efficacy more than the type of energy we use. The real challenge for improving the results of VT ablation procedures is understanding these arrhythmias and identifying optimal target sites, particularly where the use of more destructive tools without clear and limited target can be potentially dangerous. And I'll end here. Thank you.
So now, thank you very much. We have now pre-recorded presentation from Tom de Potter on ultra-low cryoablation, which is another emerging technology which might be useful for VT ablation. Okay. This is Zoom.
Dear friends, good morning. My name is Tom de Potter. I regret not being able to present to you in person, but nevertheless, it's my pleasure to share with you our experiences on the use of ultra-low temperature cryoablation in the setting of VT. These are my disclosures relevant to this presentation.
There's no voice.
Apparently part of the video. Yeah. Dobře. So they are already trying to move it to the part where it starts to move.
With the existing systems is limited. Ultra-low temperature cryoablation was developed several years ago, and we have published our experience with this technology in the setting of atrial fibrillation. We have published very efficient energy delivery of liquid nitrogen, highly compressed to what is called the near critical pressure, at which point the gas evacuation ceases to be a problem, and we can use the energy density of liquid nitrogen in percutaneous catheters. This is the system I mentioned that has been studied and made available for treatment of atrial fibrillation, and for investigational purposes, this system and this platform has been adapted to allow treatment of VT. A specific catheter has been developed, which is called the ultra-low temperature VT catheter, which, as you can see, is a catheter, a linear catheter that has active deflection, that is steerable in itself, has 8 electrodes with 1 millimeter spacing to provide high-resolution electrograms, and is capable of providing linear lesions across its length, or focal lesions if you only make contact with the tip of the catheter. In preclinical experience, very impressive lesion formation has been documented. You see here an image shared by the Bordeaux team, by Mele Soshini, where you can see lesion formation from the inside of the beating swine heart, and you can clearly see transmural lesion formation in the beating heart, despite the blood pool, of course, warming the catheter. And the Bordeaux team has further studied preclinical efficacy of this technology, have reported very efficient EGM abolishment. You can see on the left typical examples of a sharp near-field electrogram component recorded on the electrodes of the catheter, and on the right the typical aspect after one freeze application where only the far-field component remains. As mentioned, quite impressive lesion depths are achievable. You see here on the left one particular example of a 10 millimeter full thickness lesion formation. And of course, as you can see on the image on the right, one of the benefits or nice things with this catheter design is that it makes contiguous linear lesion formation possible, that it is fairly easy to deliver this lesion across the entire length of the catheter, making a full thickness contiguous lesion. This technology has been studied in the human setting, for which the CryoCure-VT study was designed, that was designed and performed with several clinical partners, as seen here on the slide, including the center in Prague. And in the CryoCure-VT study, we designed a setup of 40 plus patients. We have by now finished. I will show you in a few seconds. This is what the technology looks like in the human setting. We can use the catheter with a retrograde approach, as you see on the image on the left, or a transeptal approach. Actually, in a fair amount of cases, we use both approaches. And of course, the catheter itself is not 3D enabled, is a passive catheter which you can integrate in a 3D mapping system using the impedance tracking features of the commercially available Ensight or Carto systems. You can also obviously visualize the catheter on intracardiac ultrasound and very easily appreciate conduction channels. As mentioned, we can integrate the system in Ensight or Carto. So this is what the platform looks like. Because, of course, it is not truly Carto compatible, we have to be a bit creative with lesion tracking. We have to be a bit creative with the software, but it's quite feasible. You see here the beginning of a freeze application. You will see on the intracardiac ultrasound the freeze application. And by now we are freezing because there is a lot of noise, as you can appreciate on the real-time EGMs. And you can see that the catheter is perfectly stable. It will, of course, not move anymore for the entire duration of this freeze. And when we go to the end of the freeze, you will appreciate the difference in EGMs. You see here on the bottom the EGM before ablation, and now that the freeze has ended, you see the noise disappearing, and you see that only a far-field patients. This is what the console looks like. I'm just showing you this to show you the speed of temperature decrease, which is a typical aspect of this technology of the liquid nitrogen delivery. You can see that there is an extremely rapid temperature decrease. Technically speaking, in bench testing, we can observe a gradient of 300 degrees per second in optimal conditions. But you see here in the beating heart that we easily achieve lethal freezing temperatures minus 100 degrees Celsius at the tip, despite the blood pool heating our catheter. And this, of course, is the benefit of this technology, and this is the reason why it opens potential new avenues for treatment that previously were probably not available using cryoablation. So the patient I just showed you, our experience was very good with this particular case. The procedure time was 2 hours. We applied 8 freezes of 2 minutes each, 16-minute total freeze duration. Patient was non-inducible after the cryo delivery, and in follow-up by now more than 15 months, there have been no recurrences. We have reported our initial experience as a subset of the CryoVT study, reported and published 13 patients. You see the patient demographics here. Several of these patients have been described as case reports mentioned on the slide here. And of particular note here is that our initial experience was mostly, almost exclusively, I would say, ischemic cardiomyopathy. Ischemic cardiomyopathy because, of course, we believed those would be conceptually the most easy patients to map and to ablate. This is the summary of the procedure approaches in these 13 patients. You can see that we managed to induce VT in most patients. One patient was non-inducible. We chose substrate mapping and or combination of base mapping in most patients to identify the target region, which was then treated by cryoablation. Procedurally speaking, the average procedure time in these first 13 patients were consistent with contemporary practice, 3-hour procedure time, on average 9.6 ablation locations per patient. Spontaneously. The results, as mentioned, have been published earlier this year. The CryoCure VT study is still ongoing in its follow-up, but has completed enrollment. We have enrolled 60 patients and are now in the follow-up phase. You can see on this slide that in terms of inducibility after ablation, 7 patients of 11, I should say, were non-inducible, and 3 only had a non-clinical VT inducible. I say 11 out of 13 because, as you recall, 1 patient was non-inducible at the beginning, and 1 patient was hemodynamically unstable and was not tested for inducibility after the ablation. And then, interestingly, of course, I also mentioned that our initial experience was almost exclusively in ischemic cardiomyopathy. But there is clearly a potential benefit, a potential theoretical advantage of this technology in non-ischemic cardiomyopathy because it potentially allows a homogeneous scar creation in a very diffuse substrate. And this is precisely what has been studied in the ongoing recruitment. So the patients that were recruited and treated after those initial 13 patients in CryoCure, up to 25%, 1 out of 4 patients ultimately was non-ischemic, and very interesting observations have been made in these patients. This is a very, very nice case, I believe, that was presented by the group of Leipzig that treated a non-ischemic cardiomyopathy patient with a mid-myocardial septal scar. Typically very difficult substrate to treat with available technology due to, first of all, the location of the scar, which may be a concern with the conduction system, and second, of course, due to the patchiness of the substrate in the septum, where it is fairly difficult with RF ablation to truly eliminate that substrate. And what the group of Leipzig was able to do was scan these patients, put these patients in the MR scanner before and after ablation. And there you can beautifully see, I believe, if you look at the MR images, and the left column is pre-ablation, and then the middle column is immediately post, and the right column is late post-ablation. What you can see is that the patchy scar in the septum that is mid-myocardial before the ablation is truly extended to the endocardium and is homogenized, so to say, to a true scar instead of a patchy scar, which is an ideal substrate for re-entry, of course. As mentioned, the trial has completed enrolling, and commercial availability of the ultra-low temperature cryoablation system is expected in the European Union later this year. And finally, what is still being actively studied as the next step or the next frontier with this technology is a hybrid of cryoablation with pulsed field ablation, where potential benefits exist in terms of synergy First, the hybrid PFA cryoablation may allow shorter freeze durations for the same lesion depth. And secondly, it may enable, of course, in post-field ablation, we're all very acutely aware of, first of all, the importance of catheter stability, and second, the potential risk of microbubble formation, especially with very high PFA energy, with multi-kilovolt pulse trains being delivered. And what cryoablation does is protect the catheter, of course, cover the catheter in an ice ball. And you see here on the video that despite PFA delivery of multi-kilovolt trains, there is no bubble formation. There is zero microbubble formation in this catheter because it is covered in an ice ball of the cryoablation application. In conclusion, ultra-low temperature cryoablation has been shown safe and highly effective for AFib ablation and has now been made available for ventricular ablation using the dedicated catheter I showed you. Preclinical data indicates very deep lesion penetration in the ventricular myocardium, and early human experience supports its safety and feasibility. Analysis is ongoing, and we hope to report our final outcome very soon. Thank you very much for listening, and I truly hope to be able to share these results with you in person next time.
Piotr, sorry about the technical difficulties, but I think we got the gist of the presentation. Ultra-low cryoablation works. I have the pleasure to introduce the next speaker, Dr. Miguel Valderrabano from Houston. He has really championed venous ablation, venous ETOH ablation for ventricular arrhythmias, and he will talk about alcohol ablation today. This is an online presentation.
Good morning, everyone. Can you hear me?
Yep.
Okay, and can you see my presentation? Yeah. Okay, well, thank you. It's a pleasure to connect with you from Houston today. It's 4 a.m. here. And we'll discuss our efforts in working with alcohol ablation of ventricular tachycardia. We have used this approach for two different situations. One is the LV summit, in which the anatomical characteristics of this area make it very hard to reach through an endovascular approach, be it through the endovascular or epicardial, because of the anatomical difficulties reaching the summit. Here we target focal arrhythmias, in which in general there's previous ablations that we don't mean to create extensive lesions. And the second situation is for large epicardial or epi-to-endo ablations using epicardial veins to target large reentrant substrates where there's usually underlying structural disease scar. And we capitalize, at least for ischemic heart disease, on the fact that usually there's a vein neighboring an artery. And if there's an artery creating an infarct, there's a vein usually in the vicinity that can be used. And for that, we use the double balloon venous injection to localize the alcohol in between two balloons to deliver alcohol to the targeted region. So let's discuss a little bit of the approach first in the LV summit. As I said, the anatomy is quite complex, not only anatomically, but also its fluoroscopic projections. And if I tell you that the most important thing that I have learned in using this approach for LV summit is to use the LAO caudal, extreme caudal view that allows you to open up the angle between the great cardiac vein and the anterior interventricular vein, displaying the venous return of the LV summit, which typically has an LV annular vein, an LV septal vein, and more distal septal veins. And occasionally you can target marginal veins as well. The venous anatomy has additional complexity in the form of collaterals that can be epicardial, vein to vein, and also intramural collaterals, and we'll see how that can play a role in limiting or making a challenge to LV, to venous alcohol delivery. Let me show you one example how this is done. The key here is that you need to map the veins in order to select the targeted vein to deliver alcohol for LV summit VTs. This is one example in the extreme LAO caudal, where you open up the angle between the great cardiac vein and the anterior interventricular vein. And we're mapping here a distal septal vein with a microelectrode catheter, a 2 French octopolar catheter. You see a signal that is not bad, 30 milliseconds before the QRS, but if you map more proximally, you can see how there's even better signals you can achieve by mapping a more proximal vein. In the bottom here, you see the typical sequence of events, how we approach these cases. We first do an endocardial RV, LV, and maps of the anterior interventricular vein, and we incorporate that into the map. And then we do venograms to show the venous anatomy of the LV summit. Here in panel C, you see two septal veins, how we sequentially map these in order to define the vein that will give us the better signal to deliver alcohol. In about 2/3 of the cases, when we select a vein and we inject contrast, we see myocardial staining directly. The myocardial staining will tell you where the alcohol will go and the extent of myocardial reach by that given vein. So this is one example in which we are mapping an LV annular vein, defined as the vein that takes off from the great cardiac vein before the origin of the anterior interventricular vein. Here we have a wire and balloon in that vein, and when we inject contrast, we see staining. The contrast is staying in the myocardium and is not being shunted anywhere. So in that situation, you give alcohol and you're going to reach myocardium and you're going to create a lesion. And the lesion is where? The lesion is intramural. This is an important point. This is a direct intramural ablation. This is another example to show that intramural nature. I'm mapping here the LV outflow tract. I also have a map of the great cardiac vein and anterior interventricular vein. Look at the ablation catheter tip right below the aortic cusps in the endocardium. And I delivered radiofrequency applications that did not terminate the tachycardia. Then I superimpose the anatomy of the great cardiac vein and perform venograms. And when perform venograms, you see how there's a septal vein where I put the octopolar catheter. Great signal there. When I inject contrast directly in that septal vein, I see myocardial staining. So what happens when you deliver alcohol? Remember the location of the ablation catheter here in the subendocardium? Well, this is a similar view after delivery of alcohol. You get the immediate development of decogenicity inside the muscle. This is why I couldn't succeed when deliver ablation through endocardium, because I was not reaching the myocardium. And this is the exact projection showing the echogenicity and proving that I deliver alcohol into the targeted myocardium and not in the subendocardium. When you do use cartosound and you outline the extent of the echogenicity post-alcohol, you can see how it really matches the myocardium that we were trying to target with the radiofrequency ablation. If you do an MRI within 48 hours, you're going to see this phenomenon of microvascular occlusion, where the gadolinium does not get into the muscle and you get hypoenhancement. This, as I will show later, will become, on future time, becomes regular scar. In a few cases, the veins that we target have shunting, or they're too big, and we need to use advanced techniques to localize the alcohol into the targeted area of the LV summit. The most common advanced technique is the double balloon approach, in which we put two balloons inside a vein in order to restrict the alcohol to the segment of the vein between the balloons. So here we have a map of the LV outflow tract and the vein, over the great cardiac vein and the anterior interventricular vein on top of it. We have put the octopolar catheter in a first septal, and we have very good signals, but the very good signals are localized to the mid-segment of that vein. In LAO, you can see this is a very long vein, but when you look in RAO, you see how this huge septal vein continues deep into the septum. And this is the location of the octopolar catheter in that huge septal vein. In order to restrict the alcohol to the target area, which was somewhere in here and not deeper, we put two balloons, one distal for blockade of flow and the proximal balloon for alcohol delivery. This is a schematic of how this is done, and the idea is that we restrict the alcohol to the segment of the vein in between the balloons, and you can see if you do an MRI within 30 days, not early, but 30 days, you will see the restricted gadolinium enhancement as a chronic scar. Sometimes we use the balloon to block collateral flow. This is one example in which we had mapped a septal vein in the corner between the great cardiac vein and the anterior interventricular vein in a patient with a very tortuous anatomy. And when we injected contrast in that septal vein, we saw a very prominent flow towards an annular vein that would shunt the alcohol from vein to vein without reaching the myocardium. So in that situation, we use another balloon. We put a balloon in the LV annular vein in order to block flow, and we put a balloon in the septal vein in order to deliver alcohol. And what you see is that when you inject contrast now in the septal vein with the other balloon in the LV annular vein blocking the flow, now the contrast does not go anywhere and stays localized, and we deliver alcohol in a restricted way, limiting the alcohol reach and the ablation to that focal area that we try to use. Sometimes we've used simultaneous alcohol ablation through two balloons. So this is one such example, very similar anatomy to what I showed a minute ago, where the patient had two septal veins. We actually mapped simultaneously both septal veins, and we put two octopolar catheters. The best signal was at the distal, and when we inject contrast through the septal vein, you see the flow going back to the annular vein, very similar to the previous anatomy. And in this case, we put two balloons and injected alcohol simultaneously through both balloons, achieving an area of microvascular occlusion seen in the next day MRI. What happens to the scar after we give LV Summit venous ethanol? Well, you can see the scar develop in front of your eyes with ice in intracardiac echocardiography. You can see the intramural echogenicity, and you can outline and measure the volume of that echogenicity. Although it's not particularly precise, it gives you an accurate idea of where it is. We've done three-dimensional reconstruction of the chronic scar on MRIs, and you can see how in the green area we see the scar created by alcohol in the LV summit in the location that you would expect, with quite variable volume of the scar. We measured the volume of the scar is a median of about 5 cc's, so it's obviously bigger than what you would achieve with a point ablation. But you have to keep in mind that all but 2 cases in the series of 77 had previous radiofrequency ablation. So the scar volume is a mixture of alcohol plus the previous radiofrequency ablation. Here we show the long-term progression of the scar. If you do MRIs within 48 hours after alcohol delivery, you see microvascular occlusion or hypo-enhancement, where the alcohol does not get there and it looks super dark. And if you repeat the MRI later, either 30 days or even up to 1 year, you see how this microvascular occlusion becomes a regular gadolinium enhancement scar. We did not see any adverse events into the LV structure. If anything, the ejection fraction improved, and the diastolic dimension of the left ventricle, if anything, became smaller by virtue of eliminating the PVCs without any instance of ventricular septal defects. So overall, we've delineated the venous anatomy of the LV summit. We highlight the importance of the LAO caudal projection. We've described the double balloon approach and techniques to achieve local delivery of the alcohol, and outline the volume of alcohol ablation by ice and by MRI, and reported an overall 76% success rate after 1 year in patients that all of them had had previous ablation failures. So that's our data on LV Summit. Let's go on to discuss our work on large substrate ablation. And for that, we have compiled published a series of 44 patients with left ventricular tachycardia refractory to RF ablation. These patients underwent mapping endocardially when possible. They were mapped epicardially as well. And then we perform, after RF failure, CS cannulation and venograms, and define the veins located in the VT substrate. And then targeted those veins either with a double balloon when needed or a single balloon approach to deliver alcohol in the VT substrate vein. We try to induce, and if VT was still inducible, we would map other veins and try additional venous alcohol. So this is examples. We're here showing an example of a large inferoseptal ischemic VT from a large RCA infarct territory, where the patient had a septal infarct, as shown in an RAO view, and also a large infero-posterior infarct. Extensive radiofrequency ablation had been performed, targeting to achieve non-inducibility and not excitability of the scar, and still the patient had 2 VTs inducible. Then we map the veins, and you can superimpose the middle cardiac vein and the posterolateral vein on top of the old scar. We map the veins, and we see extensive, very late potential during pace rhythm, and also mid-diastolic signal during VT. We perform venograms of these veins, and we see in this case how this patient had a large posterolateral vein, also a middle cardiac vein that we barely see here. And in order to restrict the alcohol to the segment of the vein within the scar, we had to use 3 balloons. 2 balloons for blocking these 2 subdistal branches and 1 proximal balloon to deliver alcohol. And sequentially, we moved the proximal balloon and delivered alcohol along the segment of the vein that was in the scar. This is a schematic of how it looks in RAO and in LAO. The distal balloons protecting the distal part of the vein, and the proximal balloon for the alcohol delivery. You can see the capillaries field and the branches in between the balloons that are delivering the alcohol into the targeted segment. In this case, we later on treated the middle cardiac vein to target the septal aspect of this scar, and the middle cardiac vein was targeted from a superior approach. We cannulated from the IJ, the middle cardiac vein, and delivered 2 balloons in the middle cardiac vein and delivered alcohol sequentially in different segments of the middle cardiac vein. We could see echogenicity develop in front of our eyes on intracardiac echo, and you can outline the echogenic area and put it in your map, and you can see how the middle cardiac vein gave us a scar or echogenic area in the septum, and the posterolateral vein gave us a scar in the inferior wall, as shown here. We can use this in other locations. This is a patient with an apical infarct in the context of ischemic VT. Patient had mappable tachycardia with very small potentials, but mappable, showing a figure 8 re-entry in the apex. We ablated extensively the apical scar endocardially. The scar extended laterally, so that was ablated as well. And we also ablated epicardially. Still, the tachycardia was inducible. This was not the first ablation. What we did next is to map the coronary veins that reach the apical infarct. And you could reach the apical infarct through an anterior interventricular vein, also the distal middle cardiac vein, and also a lateral vein. All of them could reach the infarct from different vantage points. And sequentially, we cannulated those veins and delivered alcohol first in the lateral vein. That was the easiest to cannulate. They have a balloon here. I'm injecting alcohol in the distal lateral vein. Then we put the balloon in the middle cardiac vein, distally, to deliver alcohol. And then finally in the anterior interventricular vein, and giving alcohol in all 3 veins, we were able to achieve a lesion set. Finally, I think the one that was successful, that made the biggest impact, was the balloon in the anterior interventricular vein that gave us myocardial staining and increased echogenicity in the apex, leading to no inducibility. We can use this in non-ischemic VT. Non-ischemics also have veins, and this is one such example, sarcoidosis with a 3rd ablation, inducible tachycardia, large anterolateral scar. Endocardially, you can see the endocardial map and superimposed geometry of the anterior interventricular vein. Endocardial ablation didn't change anything. Epicardially, there was a large anterior scar, and you can project the activation maps into the veins, the endocardium, and finally the epicardium. You can see how there's a missing component that we don't quite see in this area. Now, part of the problem is that the epicardium has a lot of fat in the base, and you could not really see all the activations when you map epicardially. But if you map the veins, sometimes you see stuff that you could not see epicardially. And this patient had a diagonal vein, as you can see here, where we put the octopolar catheter, and you project the location of the octopolar catheter onto the endocardial map. You can see how it is on top of the scar. If you project the octopolar catheter in the epicardial map, you can see how it's also on top of the scar. And the beauty of it is that you can get great signals, much better than you can see in the epicardium when you map the veins. By entrainment, we were on the circuit, mid-diastolic signals, and we targeted this vein with a double balloon approach, delivering alcohol in between balloons, moving from distal to proximal to sequentially treat the entire segment of the diagonal vein that was on top of the scar. These are the signals before and after alcohol. As you can see here, it's a very clear abolition of the signals. the echogenicity you can see on eyes, and you can incorporate it into your map, and it matches the location of where you're targeting. How quick is the alcohol? It's incredibly quick. This is one example where we're mapping epicardially in the anterior wall. We have the upthread in the pericardium, in the pericardial space, mapping area of late activation and patchy scar in the epicardium, where you can see these late potentials in sinus rhythm. And here I am going to inject alcohol in these two diagonal veins. I have one balloon in each. And please pay attention to this late potential as I deliver alcohol. This is a live video, a recorded video during alcohol injection on Carto. And you can see how within seconds of alcohol delivery, you will see the signals disappear and the late potentials go away. Even the near field, the far field becomes a little bit blunted too. And this is during the injection of alcohol. This is an example. This is the same thing, same example, but this is the signals. These are the signals before alcohol in the left, and these are the signals after alcohol in the right. And this is the map you get. Pre-existing map had a lot of scar, obviously. The post-ablation map shows complete elimination of the areas where late potentials were happening. In the long-term effects of this, you can see pretty much like we showed in the LV Summit. If you do an MRI, within 48 hours, you see microvascular occlusion. Obviously, these patients, all of them have pre-existing scars. So you can see the lateral scar here in a patient with circumflex and RCA infarcts. Before ablation, after ablation, you see the microvascular occlusion, these dark areas. After alcohol, and then 5 months later, in this case, it's mostly all converted into scar. And same here, an example in panel B, a patient with non-ischemic VT, pre-ablation had scar in the basolateral and inferior wall, and after alcohol, you get microvascular occlusion that later on gets converted into delayed enhancement. These are the outcomes in the series of 44 patients. We had freedom from VT recurrence in 76% of the patients. Some of the late recurrence, you could argue that they were more due to substrate progression than procedure failures. The number of VT episodes was dramatically reduced after alcohol ablation, and the need for antiarrhythmic drugs was dramatically simplified. These data were published in Circulation last year. So to conclude, multi-vein, multi-balloon venous ethanol substrate ablation provides ablation that is greater than that created by radiofrequency, either epi or endo. It reduced the VT burden in RF refractory VT in a broad range of substrates, both ischemic and non-ischemic, and a broad range of locations inside the LV. Multiple balloon, multi-vein approaches are sometimes needed, and that's a complex procedure. The mechanism appears to be that we reach the tissue through the veins, creating a microvascular occlusion that later on gets replaced by scar. And the future here is the Velvet trial, which we just got funded for, and we just enrolled the first patient this week, which we're going to take patients with ischemic VT and randomize them to endocardial RF alone or combined with alcohol ablation. And I'll stop there. Thank you very much.
Thank you very much, Dr. Valderrabano, for this very nice presentation. The next presentation is by Dr. Piotr Futyma from Poland. He has extensive experience with bipolar ablation. Dr. Futyma.
Great. Hello, Mr. Chairman. Mic check 1, 2. Can you hear me? Can you hear me? Okay. Mr. Chairman, ladies and gentlemen, thank you for the invitation to present on this topic. So, as Elad already introduced, the penetration using radiofrequency of a scar of fat tissue of a fibrotic components of the valves really impairs this method. So sometimes it's really difficult to deploy a decent lesion using classic unipolar radiofrequency. This is an example. If there is adipose tissue, the value of classic unipolar ablation is very limited in such situation. You can appreciate here that in the presence of both fat and scar, the radiofrequency current cannot penetrate from the endocardium, the more distal portion. Additionally, the radiofrequency transfer can be impaired by so-called heat sink effect, because the vessels, which are, for example, in the interventricular septum or in the left ventricular summit, they provide very decent cooling effect. I always remind that for irrigation using modern radiofrequency catheters, we use like 4 up to 8 milliliters per minute, and here we have like up to 4 milliliters per second, which provides very decent heat sink effect, preventing our efficient radiofrequency delivery. This implicates the outcomes. When multi-site ablation is required, we experience a higher number of recurrences. Also, if we deal with septal substrate, the efficiency of radiofrequency ablation appears to be significantly impaired. So, contrary to unipolar ablation or sequential unipolar ablation from both sides or multi-sites, we can deliver radiofrequency current in bipolar fashion when alternating current travels between two tips of ablation electrodes. As demonstrated in this study, it results not only in more cylindrical lesion shape, but also with higher core temperature, which means that it appears more effective for true intramural substrates. This is our setup we use. We use a commercially available adapter here, and this is actually my only conflict regarding this presentation. It allows to connect a second electrode into the port of radiofrequency generator in order to close the circuit, but also allows to transfer data to 3D mapping system or EP system, and also allows to track a temperature from the thermistor located at this second ablation catheter. So typical scenario is something like this. When we deal with interventricular septum, we apply energy from all available sites with only transient effect. And here there is a recurrence of clinical arrhythmia. This happened from all these sites in this particular patient. So we deploy a second ablation electrode. We put it into right ventricular outflow tract. We can see that there is no early signal in the subaortic LVOT, and there is only some tiny signal in the right ventricular outflow tract. We can visualize both catheters during radiofrequency application. This is how it looks on CARTO, and we deliver effective lesion. So there are some less typical scenarios, like here when we ablated this patient from the distal coronary sinus and the opposite endocardium. Right now the manuscript is under review of our multicenter experience. We also demonstrated the transmurality of the lesions deployed using this method. However, it's really important to notice that it's highly dependent on the veins we have. We should provide also 5 millimeter distance from LAD target, at least 20 watts in my experience, and we should try to prolong applications. Sometimes it's inconvenient if our baseline impedance is elevated there. What we can do next, we can exchange our catheter in the great cardiac vein for a large tip electrode, and this is a nice study from Elad's group when they showed the more probability of transmurality using this approach. We also demonstrated significantly lower impedance when 8 millimeter is within the circuit. And these are some pictures from Prague from a while ago. We did 2 patients using this method, and first case was after multiple ablation attempts, like 4 ablations before, and it was very straightforward case, single application and elimination of arrhythmia. The second one, of course, online was more challenging. We had impedance issues, but we exchanged the 8 millimeter tip catheter for in the great cardiac vein, and we managed to successfully eliminate the arrhythmia. And there are some reports regarding using both large tip electrodes. In our preclinical study, we demonstrated borderline transmurality up to 23 millimeters if we use such two 8mm tip ablation catheters. So I would like to present a case of a patient who experienced multiple ablation attempts in the past, and we decided to perform bipolar ablation because of really huge symptoms in this patient. We performed ablation between great cardiac vein and LV endo. We achieved long-term effect, 4 years, no symptoms, significantly reduced arrhythmia burden. However, after COVID infection, this patient suffered recurrence. So we started with coronary angiogram showing no stenosis of vessels after bipolar ablation. We performed brief mapping. We positioned our 8mm tip electrode, and we deliver ablation like this, sequential ablation between great cardiac vein and LVOT, and also between left pulmonic cusp and LVOT, leading to elimination of this arrhythmia. What is kind of new is multipolar ablation, when they put multipolar catheter in the vein and they connect it with instead of dispersive patch to ablation catheter. What is not visible on this nice image is that actually in this circuit there was still a dispersive patch present, which means that the majority of current will flow to the patch, not to the small electrodes, but to the patch. Nevertheless, the electrodes were effective. We performed similar case a while ago when we could not get suppression using 8mm in the great cardiac vein and the second catheter in the cusp. However, we exchanged our catheter, we connected another patch to this setting, and we managed to perform prolonged applications. You can see the initial impedance, and you can see the later impedance much lower than previously with the setting of this patch. Alternative mapping sites is, for example, left pulmonic cusp. When you can make a reverse curve, you can put your catheter, and ultimately you can be successful using unipolar approach. You can appreciate how close this structure is to the anterior intraventricular vein, so anatomically it's a very decent region, and we also combined this approach in a few of our patients. We managed to put our multi-center study. You can see that there is no early activation in the pulmonic cusp, no early activation in the subaortic LVOT, some only tiny far-field signals in the great cardiac vein. Another case, the patient, after really multiple ablation attempts throughout these years without success, finally referred for us for bipolar ablation. The problem was non-inducibility of arrhythmia at the beginning of the procedure, so we performed, sorry for this, we performed sequential, we performed sequential bipolar ablation between the vein and also of the septal outflow tract. And initially we got some suppression. However, after 6 months, despite anti-arrhythmic drug treatment, this patient suffered recurrence. So we attempted reablation. We planned to do alcohol ablation. We have some experience in our center as well. However, we could not demonstrate the vein which would be feasible to approach with a balloon. We tried to advance microcatheter somewhere there. We couldn't make it. So we ended up with bipolar ablation once again. And these are two flexibility catheters. The tip is kind of flexible, so the footprint should be a bit larger in this setting. And we applied sequential bipolar ablation of the septum and between the cusp and the subaortic LVOT. We started with irrigation of using dextrose 5 in water, which contains no ions. However, we had to switch because of elevated impedance, and we continued our applications up to 45 watts for more than 2 minutes. And we successfully ablated this patient. It's like 9 months follow-up right now without any antiarrhythmic drugs. So in summary of LV Summit, we have really multiple configurations. When we include also electrodes, there's plenty of things happening there. When we move down to the septum, of course, we get closer to the AV node. We have some experience with ablation of arrhythmias nearby the AV node, and it appears safe if we uptitrate energy and track the junctional activity, quite similar to AV NRT ablation. If there is like a stable sinus rhythm without junctional beats, it's worth continuing this approach. Another case of such a patient with dominant arrhythmia with parachesian morphology. We deployed our catheters. This catheter is under the aortic valve, and the second is at the level of proximal CS. You can see some far-field signals from the His bundle. We managed to deliver longest applications of 3 minutes in this region with maximal energy of 31 watts. This is the final application when we get eradication of arrhythmia and no junctional beats. And this patient in the follow-up, he has another morphology, but the burden is significantly reduced. At this point, we do not see any indications to ablation of this particular patient, but he's still in follow-up, so we will see what happens. Some things which can be done as well is, as I mentioned, using half-normal saline. There are some reports in the bipolar ablation setting or dextrose 5 in water. In the past, we treated 2 patients like this, and the effect was quite spectacular. So all the energy goes straight to the septum, and this can be an option. However, if we would like to prolong our application and perform like a slower cooking, I think normal saline is more effective for that. And we can enhance our lesion delivery by antenna effect. We can do it by putting a wire into the septum using venous circulation, or we can put a microcatheter. Additionally, here in this case report, they applied bipolar energy for a couple of minutes until they lost the capture from inside of the septum. So this can be another endpoint if the patient is, for example, non-inducible at baseline. Some precautions. If we move more anteriorly, then, in my opinion, there is higher risk of occlusion of this distal part of LAD. I did not experience this effect so far, but there is a report on that from Japanese group. And also, if we are dealing with healthy myocardium without scar, without vessel, I think we should be aware that perhaps it's not the best option. Here is a recent case report, animal case report. You can see that there was no scar. Everything is purple, so the energy transfer would be definitely very well here in bipolar setting, and this ended up with tamponade in this animal. And of course, it is worth starting off lower energies, and actually, in my experience, we are very frequently very effective at moderate energies, and sometimes even energies below 35 watts may be desired. This is a experience from Professor Della Bella group when they applied mean energy of 33 watts. Professor Della Bella used this system which displays the distance between electrodes, which can be additionally useful. He also mentioned that it should be prevented to deliver bipolar energy if the distance between 2 catheters is below 5 millimeters. I also stick to that. Instead of that, we can show the as previously mentioned, slow cooking of the tissue. You can see that in this patient, the effective lesion was deployed after 30 seconds of prolonged bipolar application. And also, if we have a scar, I think that sometimes it may be necessary to go to high power values, as here presented by Professor Sauer's group, so-called high power, long duration bipolar ablation in the setting of 8 millimeter tip catheter. One of these catheters was actually 8 millimeter tip. This is one of our examples when we started a couple of years ago in this VT patient. We started with ablation with small tip electrodes. However, due to extensive temperature rise, you can see a bubble storm on ice. Because of that, we exchanged for 8 millimeter, and we continued our lesions successfully. Also, there are some issues regarding generators. I think they operate at different energy values. especially if we are operating at elevated impedance. This can be particularly important if there is bipolar ablation performed with two small tip electrodes. And let me conclude that bipolar ablation can be safe and effective with few precautions. It can be relatively selective. It's anatomic dependent, so sometimes we get our substrate on a table, and we need to do some maneuvers to position our electrodes. High power is sometimes necessary, and I believe that there are many possibilities for future optimization. So thank you for your attention.
Much for this very nice presentation. This session is now open for discussion. Do you have any questions? We have probably 5 minutes or so.
Congratulations to all the speakers. The talks have been fascinating. I just wanted to ask a question to Elad, because this PFA, every catheter and every platform has a different configuration of the pulse and the duration, and bipolar, unipolar. So how much do you think changing those parameters can influence the size of the lesion? And is there anything else that we can do from our end to change that, or is it something that it's going to be fixed and nothing can be done there?
It's a good question that's been around for some time, since PFA technologies are coming out. There are some class effects. So there are things that are common to all the technologies. It's an electrical field that has a specific power per centimeter, and that's determined by the design, the catheter design, the distance between the electrode, and how much energy you apply. I think the other parameters, and there are like dozens of other parameters you can you have to program. They do have an effect, but I think the major effect is actually the catheter design and the max and the voltage. In this sense, I didn't go into like what we're doing now. There is a way, in my mind or in our experience, to reduce the effect on the coronary arteries without sacrificing the effect of PFA. I think none of the companies have given any thought into this yet, because everyone thought it was very safe, and everyone wants to get to the market as quickly as possible. We do have a PFA generator that is an open, we can change any parameters that we want, and we do see that we can limit the effect of coronary vasospasm and neointimal hyperplasia by changing this. So I think that's just the beginning of the road, and I think it will be modified as we go.
Thank you.
So thank you all for the very, very interesting presentation. Miguel, I have a question to you. I don't know if you can hear me. Can you? You can.
Miguel.
You can hear us?
Miguel.
Yes, I can hear you. Yes.
Oh, sorry. So my question was, did you have the chance to look at your lateral wall ablation, the width of the lesion? I know it's very difficult from the MRI to say it. So if you have a vein and you perform alcohol ablation in a certain segment of the vein, how much is the effect, the remote from this venous structure then?
So in lateral veins, if I understand your question, you're referring to the lateral extent, or the
Exactly.
how broad or how wide the lesion is. It's impossible to tell, because I've always delivered alcohol in patients that had a pre-existing scar. So you already have low voltage around the vein. And when you compare, if you compare epicardial maps before and after, before the alcohol delivery, there was already a pre-existing scar. And what you see is the voltage goes lower, the areas of late potentials are gone, but I cannot tell you that I can measure exactly how broad, how much the alcohol lesion extended sideways around the vein, because there was already pre-existing scar. I'm afraid we're never going to do that unless we we use in animal models in healthy tissue. But I don't have the answer to that. I don't have a good way to quantify laterally how big the scar is. Does that answer your question?
Yes, certainly. Thank you very much.
Any other questions?
I have a question for Miguel. So for the last few years, we've seen your pioneering work, and it definitely makes sense, and in your experience makes a lot of clinical difference in the two categories of LV summit and in homogenizing large scars that are intramural or subepicardial. But again, even among good centers, very few are able to or have this expertise or the ability to perform what you do. So despite the fact there's many patients that may benefit from this, very few select centers are able to get good results with comfort to do them. What do you think is the future of these interventions to have a universal response, good response to those patients? Is it new tools for alcohol delivery? Are there is it like a new microcatheter that deliver energy rather than alcohol? But what's the next phase to universally apply this method?
I mean, in terms of stages, I think the next phase for me, at least, is to show not in a case series, but in a rigorous clinical trial, show that this works. And then the second step is in optimizing implementation. So that comes to now what you're referring to. Is it how easy it is to reproduce this, how easy it is to implement and to learn. Most of us have skills to get into the coronary veins. This is what we learn in years of cardiac resynchronization therapy. Now, that with conduction system pacing may go away and we may lose those skills, but we know how to get in the coronary sinus. And then there is ample room for tool development in terms of catheters. We're using balloons. I'm using borrowed equipment from the interventional cardiologist. I use horrible balloons that are usually stiff, that make kink, that are made for the coronary arteries and not for the coronary veins. I don't have a good catheter to map the veins. We use the 2 French octopolar catheter, which is good, but it's not great. So there is room for improvement, but I think the motivation to develop tools has to come from clinical data showing that this makes a difference, and that's what I'm working on with the Velvet trial. And sure, there is plenty of opportunity to develop new tools to make it easier. I do think that the opportunity that the anatomy that gives us the amount of tissue reach that you can get through the veins. I mean, the veins are there to take as much venous return from the tissue. The veins reach the tissue. That's their anatomical function, right? So we can capitalize on that. And I think the future is probably not alcohol. I mean, alcohol is just a crude toxin that is a bit embarrassing that we're using, chemical destruction. I think this technique opens the door to biological therapies and other things that can be more interesting and more sophisticated than alcohol long term. So that's where I see the future. I am sure that when it comes to tissue destruction, with PFA, with better catheters, we will reach whatever piece of tissue we want to reach in a simpler way. But there are other opportunities that come from the venous approach.
If I can just expand that question, I'm impressed by the results that you have in these patients who have had failed procedures before, especially in the VT patients. What do you tell people who want to use this technique, who are not as experienced and skilled as you are, with manipulating wires and balloons in coronary veins, you suggest, you just suggest them to come to you, or you tell them to do these procedures with an interventionalist together and get them more experience? What do you tell them?
So I think I would start by mapping the veins routinely. So I started mapping the veins easy probably 10 years ago. We would get decapolar catheter in not just in the coronary sinus, but trying to reach the veins of the VT substrate to get an idea of what kind of signals we were getting there. And the first thing you realize is that in many cases, including cases where you have epicardial mapping, because of the epicardial fat, many times epicardial mapping shows you blunted signals that look like far field, and immediately underneath you would see that the vein that's deep in the muscle has better signals. So get an appreciation of the value of the veins in VT mapping. And then in order to get familiarized with the techniques, I think you need to see one or two cases observation to see how it works. I have visitors all the time. And then many times I've had coupled visitors where I have an EP and interventional cardiologist come along with me. From the interventional standpoint, this is not something that is that hard. I mean, we all put wires in the veins to deliver left ventricular lead for pacing. So this is just a little bit of a refinement. And many times I have to tell you, I learn as I do it. If I look at my early experience, particularly in the LV Summit, many mistakes I made were because I didn't understand the anatomy. And the LV Summit is really hard to see fluoroscopically. That's why I came up with the LAO caudal projection. So it's work in progress. Is it destined to be a lost art? I don't know. But I would advise to start mapping the veins and to get an incentive at least. If you see a great signal in a vein and you're mapping endocardially or epicardially and you don't get to that vein, that will give you at least the incentive to say, okay, I need to target that. And then, call an interventionalist in the first few cases and try to do it.
Thank you very much. Are there any other questions? If not, then we'll reconvene after lunch at 1:30 or so. Thank you.
Thank you. Bye-bye.